Badminton is by far the most widely played racket sport in Malaysia. And when you look at injury rates per hour of active play, it consistently ranks among the highest injury recreational activities in the country. Most players are aware of the risk in a vague way, but assume it applies to other people, right up until the moment it applies to them. The injuries that end badminton careers and sideline recreational players for months follow a predictable specific pattern, and understanding that pattern is the most practical protection available before one of these injuries finds you. There are three categories responsible for the majority of significant long-term problems in Malaysian badminton players. The first is progressive rotator cuff damage. The rotator cuff is a group of four muscles: supraspinatus, infraspinatus, teres minor, and subscapularis, whose function is to stabilize the head of the humerus in the shoulder socket during overhead movement. Every smash, every overhead clear, every jump smash applies a high-velocity rotational load to these muscles and their tendons, and in a well-conditioned shoulder, they handle that load without difficulty across an entire session. In an unconditioned shoulder, which describes the majority of recreational players who have never done targeted shoulder conditioning, the rotator cuff fatigues well before the session ends. Once it fatigues, the larger prime mover muscles generate overhead power without the stabilizing counterforce the rotator cuff provides, and the humeral head begins migrating upward with each swing, repeatedly impinging the supraspinatus tendon and subacromial bursa against the coracoacromial arch above. The damage this causes is invisible and silent in its early stages, which is exactly why players continue training through the first post-session shoulder ache, and why the injury is often already serious by the time it forces a change. The prevention protocol takes 8 minutes, 3 times per week, resistance band external rotation with the elbow tucked to the side, prone YTW movements for scapular control, and scapular wall slides for overhead mechanics. These 3 exercises address the specific weaknesses that allow impingement to develop, and performed consistently, meaningfully reduce cumulative tendon damage risk across a badminton season. The second major category is ACL teres. Badminton's explosive lateral movement, rapid deceleration, and sudden direction changes create exactly the mechanical conditions under which the anterior cruciate ligament is most at risk. And nearly every badminton ACL tear is non-contact, caused by the player's own movement, not a collision. The specific mechanism is a split-step landing or lateral lunge, where the knee collapses inward as fatigue degrades the neuromuscular control that normally keeps the knee tracking correctly over the foot. Hamstring and hip abductor strength training combined with neuromuscular landing mechanics practice reduces ACL injury risk in court sports by 30 to 50% based on consistent evidence across similar sports worldwide. The third major category is the inadequately rehabilitated ankle sprain. A lateral ankle sprain that is rested until pain-free and then returned to without physiotherapy leaves the proprioceptive mechanoreceptors in the ankle ligaments functionally impaired. These sensors give the nervous system real-time information about ankle position during rapid movement, and when they are not working accurately, the ankle cannot react quickly enough to prevent a second sprain on the same provocation that the first one was. Most players who sustain a second ankle sprain do so with less provocation and sustain more structural damage than the first, and some cycle through 3, 4, or 5 sprains before the joint becomes a chronic mechanical problem. 4 to 6 weeks of physiotherapy after the first sprain, specifically targeting proprioceptive retraining, lateral ankle strength, and graduated return to core-specific movement, eliminates this accumulation of damage. Beyond these 3, watch for patellar tendinopathy presenting as aching below the kneecap during or after play, Achilles tendinopathy as morning stiffness and heel pain during the first few steps after waking, and lateral elbow pain from repetitive backhand mechanics. The practical principle underlying all three major injury categories is the same. The body provides early warning, the warning is consistently dismissed, and the consequence is a much longer time away from the sport you enjoy than would have been necessary if the signal had been respected. The complete badminton injury prevention and treatment guide for Malaysian players is in the link in the description. Read it before your next session.